Okay, thank you for the invitation and the opportunity to share our work on a particular aspect of transformation, and that is about taking a traditional device that we have seen for decades, but we have an opportunity to transform that utilizing new technology. I'm going to share our work in the domain, and hopefully I want to go over the slides quickly so we can save times for discussions, and despite Zoom, hopefully we can participate in some conversations. More important, we can follow through with questions or discussions that there might be afterwards. I'm listing my email address here. Please take a note and follow up in case I don't get a chance to answer any of your questions during today's session. So I am an engineer, but I spend a lot of time with doctors. My current appointment is with School of Medicine. I've taught in computer science and electrical engineering. And one of the classes I teach these days that focuses on augmenting human senses with new sensors, connected devices, and artificial intelligence. But today I'm going to focus mostly on hearing and assisting with hearing with new technology. I'm just going to start with statistics, probably share some numbers that you might be already familiar with. But still, it puts the whole topic in the context of the big problem that we're trying to solve. According to World Health Organization, 1.5 billion people around the world live with some degree of hearing loss. Among them, about a third of them, almost 500 million people, have what's called disabling levels of hearing loss. So WHO defines disability in terms of hearing loss with a certain level of audibility threshold. So if the sound around you needs to be amplified by 35 decibels, you're considered to have disabling hearing loss. And you'll have loss of productivity at work, obviously loss of communications with family members, and difficulties in social engagements, and all of those health-related issues I'm going to talk about. But that's a staggering number. 500 million people are living with disabling hearing loss. And more concerning is that this is getting worse. By 2050, WHO predicts there'll be 2.5 billion people who'll have hearing loss. Young generations are subjecting themselves to sometimes unhealthy levels of sound, whether it's through going to loud concerts or playing loud music in their ear with all of the consumer electronics devices that are coming about. And sometimes the awareness is not there. So this problem is getting worse. And I wanted to share a slide from a paper that Dr. Lin at Johns Hopkins just published. I think it's like 2 weeks ago, and he sent me a copy of his paper. This shows the distribution of degrees of hearing loss as a function of age group. So on the x-axis, you see different age groups, and on the y-axis, the prevalence of hearing loss within that population. So first thing to note is when you are over 80 years old, almost everyone's going to have hearing loss. And 80 plus is the fastest growing age group in the US. So we are living longer, we're fortunate that way. And actually 100 plus is the second fastest growing age group in the US. That's quite amazing. Another thing to notice is, we are in the 50 to 70 years, almost half of us are going to develop hearing loss. And different color codes, I just want to point to those color codes. Mild hearing loss, that's, let's say, between 20 dB and 35 dB of loss. So if sound doesn't need to be amplified any more than 20 dB for you to hear, for medical purposes, we consider it to have normal hearing. If the sound needs to be amplified between 20 to 35 dB, you have mild hearing loss. 35 to 50 dB would be considered to have moderate hearing loss. And 50 to 65 would be moderately severe hearing loss. Just to put things in context, when I'm talking now, I'm probably making between 50 to 60 dB sound. When you are inside the cabin of an airplane, you likely hear about 80 dB sound from the airplane noise inside the cabin. 65 plus is moderate to severe and greater hearing loss. So that's some of the numbers to keep in mind, and I'll be happy to explain more later on. But let me move on. So those are the numbers. And what I found through my experience is in presenting in person, it's difficult to appreciate the difficulty in the lives of patients with hearing loss just by looking at numbers and considering those numbers. So I borrowed this video from the friends at the Ear Science Institute in Australia. And this video does a great job in simulating hearing loss, so you get a chance to experience what it is like to live with different degrees of hearing loss. It's about a minute-long video. I'm going to play it. There's going to be a young lady singing a song. And first, you will hear the song as if you have mild hearing loss, and then it will simulate different degrees of hearing loss. I'm going to play it now.
I know I'm young, could be a little bit wiser, but I've had my fair share of love, and I've seen enough of pain and fire and ice to know the cold will suffice. Yes, you're surprised I'm educated. Please don't underestimate me if you cannot tolerate my opinion.
So that's severe hearing loss.
For once in your life.
This is what is called profound hearing loss. So I hope that gave you a quick glimpse into the life of people living with hearing loss. We all have somebody in our family, in our life, living with hearing loss. Hopefully that gives you a little more empathy as we interact with and talk to people. It's not just the loss of communications that we suffer from when we have hearing loss. Hearing loss has been shown to be correlated and coexisting with a number of problems. I start with the one on the lower left, anxiety. When you stop hearing things well, start to develop anxiety. And now there is a well-known correlation between going from mild to moderate hearing loss and increasing social isolation and loneliness. It's kind of makes sense that when we stop hearing people well and we have to insist on people speaking louder or repeat themselves, it's really frustrating to be in conversations. So it's too easy for people then to spend more time by themselves and be increasingly more lonely or isolated from social engagements, which unfortunately starts a downward spiral, cognitive impairment. Dr. Lin's work at Johns Hopkins have shown people with just mild hearing loss, which most of us have twice the higher chances of developing dementia and cognitive declines compared to people with normal hearing. And as that hearing loss gets worse, with moderately severe to severe hearing loss, there are 5 times higher chances of developing dementia. It's just a big problem when people live with hearing loss and do nothing about it. It has also been shown, again, work at Johns Hopkins and other places, reduced physical activity. We are doing some work at Stanford as well on studying the deteriorations of gait and risk of falling, and more important, what you can do about that for people with hearing loss. But people with mild hearing loss have been shown to have 3 times higher chances of falling and hurting themselves compared to people with normal hearing loss. And that just goes up from there. It's a big issue, not just in loss of communications, but overall health. Unfortunately, despite decades of development of technology, up until recently, these hearing aid devices were not really something to be proud of. So I'm showing you a picture that appeared in a BBC article in 2009, the shame of wearing hearing aids. And there's a lot of discussions about what all causes the stigma about hearing aids. And I would say, coming from consumer electronics domain, and today we are so familiar with devices such as AirPods and iPhones and Android phones that are just beautifully designed. This device that you're seeing the patient wearing is, not something that many of us would be proud wearing and coming to meetings or showing up in parties, etc. So perhaps the design has something to do with it. And then I have to say the quality of sound that was being produced by these devices were also suboptimal. It's not enough to amplify the sound. It's very common to hear from patients of hearing loss and wearing hearing aids. They would say, well, I can hear better now because the devices can amplify sounds, but I still struggle to understand speech or conversations in loud noise. That's their biggest problem. It's not just the loss of audibility that could be solved by amplifying sound with amplifiers, but it's about loss of signal to noise ratio. So it doesn't help if we amplify all of the sounds, the cacophony of sound, but you need to do a signal processing in a way that we enhance the sound that matters and suppress the sound that doesn't. Otherwise, just raising the overall sound doesn't help them understand conversations better. In any case, I came into this area about 7 years ago in 2017 when I was vice president at Intel working on computational perception using AI to help robots and computers to be able to recognize images. And now the world is on fire with AI. Devices that could listen to us and interact with us just through our voice. And now who hasn't used ChatGPT, etc. So, but back in between 2012 and 2017, and those of you that have been at Stanford, you know our work on AI through Dr. Faye Faley's and her group's work on ImageNet that really brought this to limelight with an amazing data set. And the ImageNet competition brought a whole bunch of researchers into this. So computer vision is totally transformed with it. But when this opportunity presented itself and I became aware and familiar with the big issue presented to patients living with hearing loss, I found it a unique opportunity to contribute with the technology that did not come into that domain by then. So I'm going to talk through 3 areas today that we have been researching and developing for the last 7 years. The first of which is using artificial intelligence to do intelligent sound processing. And I'm going to show some demos of what's possible when you use novel techniques based on machine learning and deep neural network to amplify, understand, analyze, and amplify sound that should be amplified for someone to hear and suppress the other sounds that you don't have to. So find a way to analyze and split cacophony of sound signals into different types of sounds. So I'm going to talk about that. And also modernizing the design, making it the type of devices that you will want to wear and not be having a stigma about them. The second part, which is in the middle, it's about health. If you have a device in your ear, why should you only do one thing? You should be able to have sensors built into those devices that would help you monitor your health conditions, physical health, mental health, cardiovascular health, and a whole bunch of opportunities. I'm going to share with you what we've done so far in R&D and what's ahead of us, and some research we're doing at Stanford in the domain as well. And the third aspect of it, and this is a vision we painted out in 2017, but it's now becoming very common. Your in-ear device should become your personal assistant. You should be able to access the world of information simply by talking to your devices that are invisible and are in your ear. I'm going to talk more about all these 3 things. So let me first dive into the first area, and that is about using AI to make a sound processing system such that it just makes our life easier in our day-to-day life. And I'm going to borrow a slide from neuroscience. I don't have a lot of time to dive deeper into how we hear, but I assume that most of you have this background of auditory neuroscience, just enough to understand today's conversation. What I'm going to draw your attention to is a simplified version of this from the viewpoint of an engineer. You could consider the ear, entire ear system, your outer ear, the ear canal, the middle ear bones that do an amazing job in amplifying sound by 27 decibels, to the cochlea, where you have outer hair cells that have an amazing 50 dB amplification abilities. And then finally, the inner hair cells convert the mechanical vibrations in your basilar membrane into electrical impulses that are carried to the auditory cortex through lateral geniculate nucleus as neural pulses created by the sound. And that's where the processing happens. In any case, you could say that entire ear and transduction system, we will simplify them as a combination of directional microphones, a set of nonlinear amplifiers, and frequency analyzer. Because we know in cochlea, the 3500 inner hair cell sensors are spread throughout the basilar membrane, and they are tonotopically arranged, such that in the base, we have higher frequencies that get converted into neural pulses, and at the tip of the cochlea, you have the lowest frequencies. It's almost like a frequency analyzer. So ear is an amazing device. It does an amazing job transducing all the way from 0 decibels, 20 micropascals of sound pressure, up to 120 decibels, which is the threshold of pain. That's an amazing 12 orders of magnitude in the dynamic range of sound pressure levels, sound energy levels as well. And that said, the magic of understanding sound happens in the brain, in your auditory cortex and all of the other associated areas that help us recognize the sound from the cacophony of sound streams. It helps us reduce noise. It helps us understand speech. And brain does an amazing job in doing this. Just imagine the last time that you were in a noisy restaurant, waiting for your friend to show up. You're sitting back and enjoying all of the sounds. And suddenly when your friend shows up and calls you by the name, your brain suppresses all of the other sounds, helping you to pay attention to the sound that you want to hear. Unfortunately, these amazing capabilities in the brain degrade as we age, and particularly as we live with hearing loss for a long time. There is a saying in neuroscience, you either use the neurons in your cortex or you lose them. So if people are living with moderate to severe degrees of hearing loss for years and decades, it has been shown through fMRI studies how that results in neural atrophy, essentially loss of neurons in the brain, and corresponding degradation in our ability to reduce noise in the brain and understand speech. So these two are correlated with each other. As we persist with hearing loss, as we live with hearing loss and not send those sound signals to the cortex, the loss of neurons result in a degradation of our ability to process sound. So this is well understood now, but the problem is up until now, recently, the hearing aids, all they were doing is just amplifying sound. They were not doing much in terms of compensating for the loss of sound processing abilities that happens in the cortex. So the saying in the auditory neuroscience is we don't hear with our ears, but we hear with our brain. I want to show you just a signal processing equivalent of a slide, but I won't have a lot of time to explain it. I'll do it quickly. Up until recently, to the developers of hearing devices, the computational model of the auditory system was what I'm showing on the right. Up on the top, you see the wiggly sound pressure levels representing sound that your ear receives. And in a device such as an older hearing aid, that sound will be processed in the processor of the hearing aid or a hearing device through these multiple stages. First, the sound will be digitized, and it will be passed through a bank of frequency passband filters to split the sound into different frequency bands, much like what your cochlea does. Output of that is shown here as sound signals in different frequency bands. In practice, there might be 12 to 24 of these bands. I'm just showing 2 of them here. And then the next layer of signal processing will extract the envelope from the instantaneous envelope as the output of this frequency passband filters. The next stage is an application of a nonlinear amplification. Why do you want to do that? It's sort of like copying the functions of healthy outer hair cells in the cochlea. Outer hair cells act as the natural, the biological nonlinear amplifier in our hearing system before even transduction of sound happens. So low levels of sound, the whispers and mild sounds in the 0 to 20 decibels, they might be amplified by as much as 50 decibels, and the loud sounds will not be amplified much. So it's a nonlinear function. And the theory is that the people who live with hearing loss for a long time, they lose that ability. In fact, outer hair cells loss can be experimentally measured by sending in 2 different frequencies in your ear and measuring the third frequency that's supposed to be generated because of the nonlinear amplifier in our cochlea as a distortion sound product. So we can actually measure if you have healthy outer hair cell function or not. In any case, when you don't have it, the hearing device will perform that function with a nonlinear amplification. And then we extract the amplitude of the wave of that output as well. The last level, you might have dozens of these low frequency amplitude modulation filters. And these are handcrafted filters that are developed by sound processing engineers embedded into the device. And they attempt to treat different types of sound differently, like a wind noise or a background fan noise versus a car passing by or a human conversation, a speech. They all have different frequency and amplitude characteristics. And these amplitude modulation filters attempt to treat them differently as we amplify them at different degrees. And a hearing device, when you go to an audiologist, they will tweak the parameters of hearing aids differently based on your challenges in hearing, based on your audiogram, to not only provide the nonlinear amplification, but also help you with different environments by setting the device in different ways. So this used to be the signal processing technique up until now. Our contribution to this field is AI. So essentially what we've done, the vision we had is just like what happened in computer vision. Through 2012, 2013, all computer vision used to look like handcrafted filters, handcrafted algorithms that engineers would train with in the lab and then unleash them, whether it's for face recognition and object recognition. As a result, up until 2012, 2013, the accuracy of image recognition used to be limited to between 60% to 70%, and that's it. Or it all changed when we adopted convolutional neural networks, a particular branch of DNN, deep neural network, and rest is history. The ability of computer vision to recognize human face and objects now is superhuman. It can do a better job in recognizing objects than human beings can. So back in 2018, we started researching and developing and exploring the idea of adding a deep neural network in the signal processing chain of hearing devices. Essentially add an equivalent of a neural computation. If the signal processing block shown in the blue on the top represents a engineering version of your ear system, you could consider the lower block as something that copies or mimics the signal processing that is done in your auditory cortex through the biological neural network. Well, if you lost some of those capabilities, like I explained through neural atrophy, or just years of living with hearing loss, what can the device do in pre-processing the signals and pre-enhancing the speech and reducing noise through an artificial deep neural network? Does it work? So we built a prototype first to demonstrate the efficacy of this before we proceeded to build a device. And I'm going to show you a demo. Hopefully, you will be able to hear it and feel for yourself the differences between an old hearing amplification device that will just bring up sound levels, all sound levels, amplify them. And then I'm going to show you the second half of this demo. That will be where the sound will be passed through a deep neural network that is trained with real-world data of noisy sound to clean speech pair. And millions of the sound samples will be used to train this deep neural network. So please enjoy this demo of a deep neural network.
That light is red arrow. So there was green for the straight ahead direction. And the arrow was red. And I'm just staring at it for a moment thinking, this is really strange. For a good 2 or 3 seconds, I'm seeing cars, 2, 3.
Okay, so I hope you saw the first half of the demo was noisy. It was in a typical cafeteria environment, which is where the sound was recorded, this conversation. And the second part is when we passed that same sound through a deep neural network, that special purpose deep neural network that was trained with sound samples and curated for raw noise reduction and speech enhancement. I'm going to play it one more time so you can listen to the before and after one more time.
I looked up and that light is red arrow. So there was green for the straight ahead direction. And the arrow was red. And I'm just staring at it for a moment thinking, this is really strange. For a good 2 or 3 seconds, I'm seeing cars, 2, 3.
So this was quite inspiring for us back in middle of 2018. When we created this demo, it gave us confidence that this technology is going to change the way hearing amplifiers and hearing aid devices work. It gave us the confidence to invest the money we need to build a special chip with a deep neural network built in, and there's nothing off the shelf. So we literally had to invest, north of $100 million in developing a product with special purpose processor chip, including hardware accelerated low power deep neural network on it, and building a device that I'm going to show you soon. So let me switch gear to the second part, which is monitoring health. Why should the hearing device stay as a single purpose sound amplifier when every other product in our life are multifunctional? Think of your iPhone. Prior to the introduction of iPhone in 2007, phones used to do one thing: help you make a phone call. Today, what do you do with your smartphone? In fact, what is it that you do not do with it? It's your camera, it's your GPS device, it's your internet browser, it's everything in your life. The device that is in your ear, it should be able to help you with your health besides helping you with your hearing. So let me walk through a couple of things. First, we embedded IMUs, tiny micro electromechanical sensor devices in this modern generation of hearing aids that is the most accurate tracker for your physical activities, your steps, your exercise, and your move. And ear is the best place because head doesn't flail around like your wrist does. So we're able to quantify people's physical activities a lot more accurately than sensors placed in other parts of the body. And I talked about fall. I'm showing you data from Johns Hopkins that people with mild hearing loss have 3 times higher chances of falling. And every 10 dB of increase from the mild hearing loss results in 40% higher risk of falling. This was from a large-scale study done at Johns Hopkins. So we challenged ourselves to see if we could build an AI classifier in our hearing devices that has sensors and AI to accurately detect fall. And turns out we could. So with data initially collected through robots and mannequins falling in the lab, and eventually data collected from hundreds of thousands and millions of patients that are wearing devices, going about their daily lives, we were able to develop a highly accurate fall classifier. In fact, we have the most accurate fall detector device of any devices. Again, 2 devices on 2 sides of your head. People are always wearing them because they need the people who need them for hearing. This comes free for them, almost like an additional feature. And so the device can automatically detect if the patient fell, and it sends alert messages to the loved ones. And this sort of is amazing. Every time that I'm presenting somewhere, I would hear people say this is life-saving. In fact, one of our patients who agreed to speak with Wall Street Journal about it had fallen in the driveway in icy Minnesota during the winter months and fell unconscious. The hearing devices with fall detection detected that he fell, sent alert messages to his wife and kids, and his life was saved. So he felt compelled to share his story with Wall Street Journal, and it just changes my perspective on the work we do in reaching out and doing a little bit more for devices rather than staying limited to the basic functions. And I want to share a couple of slides on work we're doing at Stanford. I believe we are getting close to publishing it. We've already published in a conference, and it's going to be submitted to a journal soon, where the same devices trained on 250 patients at Stanford Medicine were able to show that we could help people assess the risk of their falling before the fall using CDC's STEADY protocol, which is stopping elderly accidents, deaths, and injuries. That includes 4-stage balance test, 30-second chair stand test, timed up and go test, done purely with the assistance of hearing aids in your ear. So we took these patients and had them being evaluated by balanced neurologists like Dr. Kristen Stinnersen in Stanford Otology and Neurotology and her colleagues. And then we had hearing aid devices doing it automatically. And we wanted to see if they agree, the AI and the human professional. And it's pretty amazing results. So first here you're seeing 4-stage balance test. How does hearing aid in the ear with sensors tell whether you're trying to do a tandem step or you're trying to balance on one foot? It turned out when you have the AI system trained really well with data, it can do a fantastic job. We have 86 to 93% scoring agreement between the AI and hearing aids and the balanced neurologist at Stanford. It's pretty amazing. And next, 30 seconds chair stand. Very good correlation between human observer and the AI system, its ability to accurately monitor this. And the last thing I'll show is the timed up and go. Again, very good correlation between the neurologist observations and the hearing aids AI doing it automatically. So we're going to be rolling this out as a feature after we publish the paper, and to be a joint published paper between Stanford and Starkey R&D. That just shows the step-by-step progress in taking hearing aids and turning them into a multifunctional health device. And as we speak, we are getting ready to do another study. And at this time, we will have multiple sensors built into the devices that can measure heart rate, SpO2, and also temperature in the ear, the body's core temperature, not on the wrist. So this would be a study done with Stanford School of Medicine, where we're going to explore the potential for developing an early warning system for people's cardiovascular health, respiratory health. I did mention respiratory rate as well, because the microphones can pick it up. So I hope I'll come back to share the results of that study in the future. And along the health tracking, the next thing I want to talk about is mental health. not just the physical health. I borrowed this slide, the data for this slide from Dr. Vivek Murthy, who's the US Surgeon General. He calls loneliness in the US an epidemic. And the data shows people who are isolated and lonely have 32% higher risk of dying, etc. So the rise in the risk of stroke, just staggering effect. So we challenged ourselves to see if the AI in the hearing aids can classify the onset of loneliness and lack of social engagement and make their loved ones of the elderly patients aware of it, of course, with the patient's permissions. And it turns out with machine learning analysis, we can determine the level of social engagement. So if my mother was highly engaged and interactive in social environments before, but over the last few months, she has been increasingly isolated and becoming more and more lonely. I want to know that, with her permission, of course. And the machine learning's ability to analyze this is quite amazing. So this is a feature as well that's made available. And before I wrap up, I want to take a couple of minutes to talk about this idea of personal assistant. So the device has microphones. It's got a processor that analyzes sound, and it's connected to the cloud all the time. It has Bluetooth pairing with the phones, and it's in your ear. And people don't even sometimes know you're wearing them. So it's unfair to ask you this question that I'm going to ask you now anyway, because I'm not in the room with you. Did you notice I am wearing these devices myself? I don't have any hearing loss yet, but I am wearing these devices, testing it. And even when I'm in the room with a room full of people, when I pull out the devices, they go, wow, I did not realize you're wearing these devices. So they're a tiny little electronic device that goes right behind my ear and sits there. And a translucent wire sends the sound signal into my ear, and I have on both sides. I use them as my Bluetooth headset with 50 hours of battery life. So they're my listening device for audiobooks, meetings, YouTube, lectures, etc. But they're also my tracker of health. And yes, they're my personal assistant. So what can I do with them today? Okay, I can translate languages. Yes, it sounds like science fiction, but I can talk to my gardener. When he speaks Spanish back to me, my device translates English. 72 languages we can translate back and forth between. Transcription. If you're in a particularly challenging environment and you have 70 dB hearing loss, the device will send transcribed text to the screen of your phone through the app. So just as the device is amplifying sound, you'll see transcribed text on the screen of the phone. And yes, it is my personal virtual assistant. I can double tap or discreetly press a button on the device or invoke it from my app. I can ask any question and get an answer spoken in my ear privately that no one else hears. Who's the president of Timbuktu? Or what's my next meeting? What's the weather tomorrow? Who won the Super Bowl in 1982? And with the world of LLMs, you might want to consult a virtual agent for many different things, your travel needs, rudimentary questions about your health, and whatnot, politics. So imagine this device becoming the conduit to the world of information. And so I was sitting down with a reporter from Bloomberg to show him the demos and talk about this product. And I wanted to share the headline from his article that resulted. He said, the future of wearable technology is called a hearing aid. And he said, even if your ears are fine, you might want a device that translates languages. He said 27, but now it's over 70 languages, tracks fitness and monitors vital signs. Everything I presented today is published already. This is an overview article in IEEE Computer. I'll be happy to share with you. If you send me a request, I'll share. The device is available through Stanford Ear Institute, Stanford Audiology, and many other places. For those of you who want to try it, or a loved one who wants to, who's been burned with hearing aids don't work and wants to utilize AI to see if that helps better, feel free to reach out to me. And I'd love to see what questions you have. Dr. Osdalga, I hope we have a few minutes left for some discussions.
Yes, Dr. Bhowmik, thank you so much. That was really wonderful. I was thinking I have to thank Dr. Schulman for inviting you, just hearing how amazing this presentation was. We usually have a couple questions at this point, and they come. We already have more than 5x that to start, and I imagine more will come. So I want to start getting into the questions now to try to get through so many as possible. I'll start with Dr. T. She asks, do you have any special device to reduce tinnitus? It'll be beneficial for many patients.
Thank you for that question, because of the brevity of the presentation, I had to leave that part out. So first, for the rest of the audience, tinnitus is a health condition where people, many of them living with hearing loss, but sometimes even people who have normal hearing, but mostly people who live with hearing loss, they'll tend to hear phantom sound. It's a sound that is created by our auditory cortex. And it can be annoying for some people and could be just debilitating for others. Loud, crickety, chirping sound that you always hear and you can't do anything about it, apparently. So yes, we have an active research project on that, and the results are promising in that with hearing devices, we have the ability to personalize masking sounds for tinnitus patients. And the phantom sounds tends to take a backseat and go away when you are feeding real sound into the auditory cortex. And over days and weeks of use, we have had many patients who have suffered from unbearable tinnitus. Their lives are better now. So please reach out to me and I'll be happy to share a lot more details with you.
Great, thank you. Before I go, I'll go to Dr. Vasquez's question next, but I want to check in with Dr. Verghese and queue you up. Great, I see you turn on your Dr. Verghese, I'll turn it over to you.
Hi, Dr. Bhowmik. Thank you so much for that wonderful lecture. Some hope for the future. I'm also a hearing device wearer, and I can identify with all the things you mentioned: the isolation, the difficulty in noisy situations. I wondered whether we have reached the optimal scientific advances for the hearing devices themselves. For example, I'm wearing a new kind of device called ear lens, actually developed by a Stanford NT pioneer. You're familiar with it, but for the listeners, it involves a contact lens-like device that sits on my tympanic membrane. And this thing that looks like a hearing aid is actually simply transmitting frequencies to the contact lens, which vibrates. And it has given me back all the high frequency that I had lost, so I can enjoy music better. So I'd love to see more advances both in this and in the interpretive technology. Yes. The other thing that I think would be, I'm not sure, but obviously I don't have your capability to make that happen. It would be wonderful if the kind of transcription or closed captioning that we see, in television and in movies could be somehow reproduced in real life conversations, so that you might be able to both listen and read when someone is speaking. Right. Do you have any knowledge of those advances? And thank you in advance.
Sure. Thank you, Dr. Verghese. Those are 2 points you brought up. I want to address both. First of all, I am a big admirer of Dr. Parkins, and I know him quite well. We meet very frequently to talk about technology and how we can collaborate. EarLens was his brainchild. So the way that first you ask, did we saturate? I don't believe so. I believe as an engineer, we're on the cusp of a major improvement in hearing aids and hearing devices in 2 ways. First, the improvement in the transduction itself. And that's, you mentioned about frequencies. So the old hearing aids were limited in the sound frequencies they could deal with, perhaps from half a kilohertz to maybe 6-8 kilohertz. Clearly not good enough, because natural sound or normal biological human ear, theoretically in auditory neuroscience, we learn they can be sensitive from 20 hertz to 20 kilohertz. But even if it's from 250 hertz to 10, 12 kilohertz, we need to expand that frequency dynamic range. And EarLens is an attempt to doing that by placing vibrators right on the eardrum. And hearing aid transducers are also widening and getting better and better. Dynamic range in the amplitudes are also getting better. But all of this, I say transduction. I believe the big breakthrough is going to be in the neural network-based sound processing that I just presented. And hopefully you heard the demo where we would be able to pre-process the signal in real time with less than 5 milliseconds of delay and only amplify speech when you want to just have a conversation. And you are in a loud and noisy environment and you don't want the background sound to be amplified. It's being done through advances in directional sound processing with multiple microphones. And it's being done through the deep neural network-based machine learning approach to sound processing. I'll be happy to meet up with you and have you experience what the state-of-the-art devices do. And then I'll share with you what I believe is going to happen in the next 2 to 3 years. It's going to be magical. I'm quite excited about it. And yeah, so I'd say that, so it's like, unfortunately, it takes months, years before the breakthrough results come into shipping devices. But we are moving much faster than we could in the last 2 years.
Thank you, Dr. Bhowmik. Excited to hear that. This next question comes from Dr. Rosalind Vasquez, and it's by far the most upvoted question, by the way. Thank you for a great presentation. Cost is quite a barrier to adoption of hearing devices. Can you comment on the less costly over-the-counter devices? What is the expectation for costs for the more intelligent devices you described? Can we get those to patients, those high-quality devices?
Thank you for that question. So it's well known that getting hearing health is expensive. Just like healthcare in the US in general is, I wish it would be a lot more affordable than they are now. And what I'll share though is the steps we are making towards making things better. So first, if you just kind of look at, so let's take an example. Let's say if you walked into a high-end audiology clinic in Palo Alto, a most advanced pair of hearing aids plus the services from the audiological services you get, it might cost you $6,000. Vast majority of that, probably about 80% of it, are not going into the devices. They're going into the services of the professional. And for those of you that have seen audiologists and been into their offices, you probably think they deserve it, because it's not just simply putting a device in your ear and letting you go. They will do audiological evaluations for your audiograms. They'll do otoscopic examination and clean your ear and look at the quality of your eardrum. They might do sophisticated testings to measure compliance of your inner ear system, and perhaps even the functionality of your cochlea, your word error rates, etc., and then program you with hearing aids. And more important, they will have repeat visits free. They cover it, right, for years to come. And you could lose your hearing aids. They'll replace it. So all of this, unfortunately, is expensive. And I said in Palo Alto, it might cost you, $4,000 or $6,000. And then in other areas, they might be cheaper. You mentioned over-the-counter hearing aids. So recently, thanks to the work from FDA, there's a class of devices that they now approve us to ship directly to patients without requiring you to go to a medical professional to get class 2 medical product. First, I have to say, having observed this for a year, it is not taking off, unfortunately. Even the costs are lower, because we humans still like to go see a clinician, and they would do a lot more in understanding my personal challenges and helping me overcome. But I do believe with progressing technology, where we can do a lot more in automating the self-fitting process, I believe in the future you'll start to see costs come down, and the patients will be able to do a lot more by themselves, taking less and less time from expensive services. So watch out this space for the next 1 to 2 years. I believe that through regulation, easing of regulatory requirements, and through advances in technology, this is going to get be on an improving curve over the next year, 2 years.
Excellent. Interesting question for Dr. Cartwright. Is there any data showing efficacy in those with a specific inner ear issue, Meniere's disease? So you have that ringing of the ear you talked about, the hearing loss, it'd be interesting. Can this help minimize specific diseases?
Yeah. So interesting you bring it up. So one of our famous patients who just recently came to get evaluated is a famous musician, and he's on speaking circuit now and talking in public in mainstream television interviews how his Meniere's disease resulted in loss of hearing in both ears, and he was struggling to perform. And now with these devices, he's able to hear better. And we have helped him by making the setting dynamic. The challenge with Meniere's disease is your level of loss fluctuates. So we're able to help these patients by setting the ability to change between different levels through the app. And yeah, it's quite helpful.
Excellent. We'll go from Dr. Kari's question to Dr. Should we do wider audiometric screening and use in a much milder hearing loss to prevent downstream complications? These devices look amazing. I think people are going to want to wear them more.
Thank you. Thank you for asking the question. In fact, that's what motivated me to focus my work. I moved from primarily working on vision and a little bit on sound to primarily working on sound and a little bit on vision. So, it's all computational perception, but the vision I had and I still have at this time is that if you are able to translate these technologies into devices and ride the waves of regulatory easing, I believe we'll be making devices not too far from now that each one of us will want to wear. People like me, I'm already wearing them just because I can afford to get devices that I make. But each one of you will benefit from it, and you don't have to have hearing loss. Let me just give even if you have normal hearing, let's say we have normal hearing, who doesn't struggle to hear a conversation in a restaurant? So if you have devices in your ear, nearly invisible, and it gives you 8 to 10 dB better signal to noise ratio because you have directional microphones and you have neural networks enhancing speech and suppressing noise. All of us will benefit from it. Tracking health. We all track our health through Apple Watch, through Fitbit, through our devices. Now your hearing aids can help you do that more accurately. Personal assistant. You don't have to take out anything from your pocket. You simply say, hey, your favorite assistant. It could be ChatGPT, it could be Claude 3 from Anthropic, and it's accessible right away through the microphones to the speakers in your ear. Everybody will want to use them, and I believe that technology is advancing to the point that I can see it start to happen sooner rather than later, where maybe I'll make them consumer devices, price them much lower, so that they are, while for severe hearing loss, people are going to audiologists, people with mild to no hearing loss are using devices off the shelf.
What I love about what you're talking about is so much of the future of medicine. I have a couple of questions here from Dr. Wang asking, can you anticipate adding sleep evaluation to the analytics? And Dr. Milstein asking, how about the capacity to continually estimate blood pressure?
Thank you very much for that. So we're actually currently exploring, I mentioned a study at Stanford that's coming up. Sleep will be an important part of it because we have these new devices that are not yet commercially available, but they're available in quantities for evaluations and studies. We have SpO2, we have heart rate, respiratory rate, and core temperature. These are important biological parameters that professionals like Dr. Robson Capasso would measure in his sleep labs for patients with sleep disorders and sleep apnea. So we're going to explore whether these devices could become a remote monitoring device while the patients are sleeping with them at their home, so that they don't even have to come to a sleep lab for most of their real-time monitoring of either improvement or degradation of their sleep quality. We are quite optimistic about the ability to do that, and which will enable the professionals of sleep research to extend their analysis abilities to patients' homes. And just stay tuned on this. And for those of you that are interested in learning more or maybe even working with us on this or exploring partnership with the study that we'll do at Stanford Medicine, please feel free to reach out.
A question here, and I might go, if it's okay, a couple minutes over, if that's okay with your timing, Wes.
That'll be good.
Will additional proposed features of your device make it harder to pass regulatory hurdles?
That's a good question. Thank you. So initially, that was a big concern. And through a good interactive dialogue and collaboration with FDA, I don't believe that's a concern anymore. So we were able to bring fault detection feature into the hearing aid, into market, and FDA did not require us to pass any hurdles for it, because we had the data showing the accuracy of the technology, and they're mostly concerned about, is it creating harm among people? Well, if we're going to automatically detect if somebody fell and the person already fell, so hearing is not pushing them to fall. And then this work that we're doing on assessing the risk of falling, of course, we're going to have data through the Stanford study showing the correlation between professional studies and this AI results that will allow us to make the claims we want to. And then the studies that we are planning to do now on cardiovascular, sleep, etc. We are always wanting to get good quality data from patients, so that we're able to stand behind the accuracy and efficacy of this feature. So I don't expect to see hurdles in bringing this to the wearers of hearing aids into the market.
Dr. Chu asked a question. It might have a 100-year-old friend suffer from severe hearing loss for 10 years. Is it too late for him? Is there any limit to this technology? Patients it sounds like it's never too late to receive benefit from this. Would you say?
Yeah. Good question. Thank you. So where it cannot help, if the cochlea is completely dead, if we have some patients whose inner hair cells and outer hair cells are completely gone, but their auditory pathway is intact, so they are candidates for cochlear implant. So there you have to surgical implant electrodes that will basically provide electrical stimulus directly at the nerve ending of the auditory nerve fibers. But that said, many cases when we have had patients come and they say, I don't hear anything, and they would walk out with hearing devices, and we will, of course, instrument them with the loudest possible amplifier. We can go up to 70 plus dB amplification. That's huge. And these people walk out saying, wow, I can hear now. So we would not give up on anyone, at least we would try. So please reach out if we can take a look and evaluate and see if we could help with hearing devices. Perhaps when people come in with 80 dB loss, they pretty much don't hear anything. Because when you're speaking, we are making 50, 60 dB sound. If you have the 80 dB loss, you're not going to hear anything. And yet, with very powerful hearing aid, they're able to hear.
Dr. Bhowmik, thank you so much. We're hitting just a few minutes past. For the remaining questions, if I could say, you have mentioned your email a couple of times. You have it up now, and we'll send it out if it's okay with you, with the recording of this video to our community as well. If anybody wants, please email me and I'll connect you as well for the remaining questions, or if you have future questions. Thank you so much for sharing. This really is an insight of the future of medicine in so many, not just about hearing, but so many ways. So thank you for sharing this amazing technology. Hopefully in the future, we can invite you back for future iterations as well, as I imagine it's going to continue to grow on top of what you've already done. Thank you for...
I'll be happy to do that. And thank you, Dr. Osdalga, and thank you everybody for listening.
Yeah, thank you everybody for sticking with us past the hour, and have a great rest of the day.
The preceding program is copyrighted by the Board of Trustees of the Leland Stanford Junior University. Please visit us at med.stanford.edu.